These are my disclosures. None of them are really relevant. What I'm going to be doing is just looking at the perspective of active surveillance in Canada, focus on the management problems when patients are referred for radiotherapy after progression on active surveillance, the evolving role of imaging, predictive tools such as nomograms and genetic profiling, and the influence of stage and grade shift. So the first clinical trial in active surveillance in Canada began in 1995 in Toronto by Dr. Klotz, basically for favorable risk disease or intermediate risk if the patient was over 70 and it was a Gleason 3+4, or you could have a PSA between 10 and 15. Since 2002, when Laurie published the first paper, he has been involved in 75 publications and 44 first author articles, including 9 in the Journal of Urology, 8 European Urology, 4 JCO, 5 CUAJ, and 2 World Journal of Urology. So this has been a very widely publicized, highly advertised form of approach. So in Canada, because Laurie is Canadian and one of our leading urologists, the active surveillance approach is widely accepted, and as Laurie's outlined, it has been very broad-based and inclusive. And what is involved is a PSA every 6 months, a repeat ultrasound-guided biopsy at 6 to 12 months, and then again at 3 to 4 years, with the criteria for intervention evolving along the way. PSA doubling time was initially considered important, less than 3 years. It was less than 2 years up until 1999. Since 2009, if the PSA doubling time was less than 3 years, they would go for either a biopsy or a multiparametric MRI. There'd be intervention if they were upgraded on repeat biopsy to 4+3 or palpable clinical progression. So the results of this in the province where I work in British Columbia, the BCCA Cancer Outcomes and Surveillance Report from 2013, a third of men newly diagnosed with prostate cancer in the province were not initially treated. So I think that's a pretty good indication of how widely this is accepted. And also in the British Columbia Brachytherapy program, we have a very active program that's treated over 5,000 men. In the first 5 years of that program, from 1998 to 2003, 1,000 men received low-dose rate brachytherapy. 58% of these had favorable risk disease. In the 2-year period from October 2011 to September 2013, similar number of patients, 8% were favorable risk. We've almost stopped treating them completely. What's happening with this? What are we faced with now as a radiation oncologist because of this active surveillance? So I'm going to present a few cases which I think you'll find interesting. This first guy was a very healthy financial advisor at the age of 68 in 2010. His PSA was 7. Prostate ultrasound volume 44. So he had a biopsy and it showed 0.5 millimeters of Gleason 6 tumor in the left apex. Active surveillance was appropriately selected, and he had biopsies again in July 2012, September 2014, both of them, both sets, which were like 8 to 10 cores, completely negative. I haven't put down all his PSAs, but the PSA kept marching steadily upwards, and by August 2015, it was 24. With a doubling time of 29 months. Staging was done, it was negative, so he was referred for radiotherapy for high-risk prostate cancer. Well, the only pathology we've got is 0.5 millimeter of Gleason 6 from like 6 years ago. So I know a lot of my colleagues would say, well, his PSA's up, we treat. Do we re-biopsy? He's already had 3 full sets. Do we re-image? Well, yes. We were able to re-image. This happened very fortuitously at the time when we now had multiparametric MRI with an endorectal coil in the local hospital. In fact, he was the first patient that I got in. So this is his MRI, and you can see here that anterior smudged charcoal sign of an anterior lesion, which shows up as a black hole on the ADC images, and gadolinium early enhancement as well. So I reviewed these with the radiologist because all our ultrasound-guided biopsies are done in radiology, showed him the MRI. I said, can you hit this? And he said, well, I'll do my best. And he did. You can see the ultrasound image in the bottom corner there with him targeting that anterior lesion. And he got 11 millimeters and 18 millimeters of a Gleason 4+3 with 80% pattern 4. So now he's truly high risk. PSA is 24, 80% pattern 4, and also the multiparametric MRI suggested extracapsular extension anteriorly. So for him, we did trimodality treatment with a year of ADT, external beam to the pelvis, and brachytherapy to optimize the dose escalation to the prostate. Another example, this guy was 72 back in 2010. Biopsy showed a single core of 2.5 millimeters, Gleason 7 in the right transition zone, 3+4. Active surveillance was selected, but no further biopsies were done. They did continue to follow the PSA. Its doubling time was 53 months, going up at a rate of 2.3 per year. And by 2015, 5 years later, it's over 20. So they finally did another biopsy. Prostate volume was 112 cc's, only 10 cores were taken, and all were negative. So he was referred for radiation for high-risk prostate cancer, again, based on his PSA and that single core from 5 or 6 years ago. By the time I saw him, his PSA was up to 22. I repeated his staging. It was negative. We got a multiparametric MRI. The lesion shows up best on the ADC map here as the black hole, and that was able to be targeted, and it was a Gleason 7, 30% pattern 4. The dilemma is now he's still healthy, but he's like 77, 78. His PSA puts him into a high-risk zone. Do you continue to watch? Some people would. He preferred treatment, so we were able to shrink his prostate a bit and treat him with brachytherapy. Next case, 59-year-old maintenance worker with the railway, August 2011, PSA 7.3. First biopsy shows a millimeter of Gleason 6. Active surveillance is selected. August 2012, repeat the biopsy, same thing. And you can see the PSAs here marching steadily upwards to May 2015 when it's 15, and doubling time is 63 months. So he's referred for radiation again because of the PSA level. On examination, I got a big surprise because he has this whopping big T2B, really obvious nodule on the right side. How could they have missed that? 6-centimeter prostate. IPS score was fine despite the large prostate. His last biopsy had been 3 years ago, and it only showed this tiny focus of Gleason 6. And, well, look, you've got this huge nodule here now. I think we should just go right ahead and rebiopsy. Well, that's 12 cores, small focus Gleason 6 with some high-grade pin. His prostate volume was 77 cc's. At that time, we didn't have the multiparametric MRI. We didn't have endorectal coils. We got just a regular MRI, 1.5 Tesla, not very helpful. Biopsies were repeated, again, 2 millimeters Gleason 6 in the right mid. So the guy didn't want anything done. He said, forget the PSA, I'm fine. So we continued to watch. 6 months later, PSA is 15, staging's negative, and now we've got multiparametric MRI. So you can see the lesion. I mean, this is what we were feeling, this huge thing on his right side. You can see it on T2 as well. There's also a smaller lesion on the opposite side, which isn't as prominent. And so we repeat the biopsy. And this guy's had 5 previous sets of biopsies. So the lesion's documented on the MRI, and you can see his pathology here. 7 out of 10 cores are positive. It's 20% pattern 4, 10 millimeters, 5 and 7 millimeters here, 3+4 from the lesion, and smaller volumes throughout the rest of the prostate. He's been on active surveillance for 5 years. Now he's got 7 out of 12 cores positive, 20% pattern 4, prostate volume 77 cc's. I was thinking of brachytherapy for him, but he had significant pubic arch interference, so I downsized him for 8 weeks, and he had his brachytherapy and did quite well with that. Pre-plan LDR, pretty standard. And the post-plan dosimetry was fine, and he's done very well with that. Next case, 59-year-old, 2009, PSA of 4. Biopsy shows 5 cores positive out of 8. 3+3 and 3+4, small prostate, 21 cc's, but 3 of the cores were less than a millimeter, and the 3+4 core was 4 millimeters. So he was another man that went on active surveillance, fits the criteria for the Toronto criteria. At the same time, he was also placed on dutasteride and tamsulosin. 3 years later, PSA was 2.6 on the Avodart, which means it had risen slightly if you double that. So they repeated a biopsy. It's now 4 years later. And it was 3+3 and 5 out of 15 cores, all pretty low volume, 1 millimeter, 2.5, 3 millimeters. November 2015, PSA is marching upwards. It's now 5.9 on Avodart, which is 11.8. Biopsies were repeated, and now it's 4 plus 3, 50 to 60% pattern 4. He has quite a small prostate volume. He's otherwise fairly healthy, and so you can see the disease here. He's got 5 millimeters, 3 plus 4, 5 of 4 plus 3, and another 3 of 3 plus 4. So I'm considering him for brachytherapy as well. He's been on active surveillance for 6 years. His staging is clear. He's got a small prostate, good voiding function. But I was a little concerned about the apical lesion, so I did do a multiparametric MRI to make sure that monotherapy was going to be the right approach. So here you can see his lesion on the T2 images. So he's got this apical lesion. There was no evidence of extracapsular spread. However, on the ADC images, you can see the lesion here, the apical one that we know about, but he also has this anterior lesion, which we didn't know about. So there's no extracapsular extension. We don't know the pathology of the anterior lesion. I decided I would go ahead with brachytherapy as monotherapy. He's on a monotherapy trial, so he's randomized between LDR and HDR. Both DILs were positive on directed biopsies and had a Prolaris score of 3.5. He went off his dutasteride, had his brachytherapy. At 4 months, PSA was already down to 1, and at 6 months, it was down to 0.9. We can skip through the plans. It was a good implant, good dose. So, summary of active surveillance consequences. The real disease can be really hard to find. All these patients had been on active surveillance for 5 to 6 years. Case 1 ended up with high volume 4 plus 3 with extracapsular extension, so he got the triple modality of ADT, external beam, and brachy. Case 2 by that time was quite a bit older. We ended up treating him with 6 months of ADT and brachy. Case 3, we had to downsize him. We would have had to anyway because his prostate was large. And case 4 ended up with brachytherapy as monotherapy. So the extent of disease that you find after a period of active surveillance certainly changes what you have to do for these men. So men with Gleason 6 prostate cancer are certainly eligible for active surveillance. Gleason 6 may have no metastatic potential, as Laurie showed in Edgerton's trial, 12,000 radical prostatectomies. The rate of distant metastases at 20 years is 0.2%. And Louis et al. Published 22,000 radical prostatectomies, all confirmed Gleason 6 with a lymph node dissection, and lymph node positivity was 0.5%. But as Laurie said, higher volume disease is associated with harboring pattern 4, and the problem here is the misattribution, as Laurie said. I love that word. Can we select men with apparently low-risk prostate cancer who should be treated at diagnosis? And what are our tools for doing that? Multiparametric MRI, genetic profiling. So you've seen these criteria for surveillance. As you know, the Toronto criteria have been more broad, including the pattern 4. I'm glad to hear that we're going to be moving away from that. If you take these patients that would be appropriate for active surveillance, what happens when you operate? And Wong published on 2,300 radical prostatectomies from Australia, the UK, and Canada. 800 met the Toronto criteria, 410 the Prius criteria. And in the Toronto criteria, 50% were upgraded and 18% upstaged. Prius criteria, because they're more stringent, the numbers were a bit lower. So what are the results of a liberal active surveillance program? Almost 1,000 patients, 15-year cause-specific survival is 94%, 2.8% distant metastasis rate, median time 7 years, and as Laurie pointed out, these are going to be the guys with the pattern 4. At 10 years, 63% remain on surveillance, and at 15 years, 55%. The prostate cancer mortality is increasing. Non-prostate cancer mortality compared to prostate cancer mortality is about 9 to 1. In the previous publication, it was 19 to 1. So as you get longer follow-up and get out to 15, 16, even when we get out to 20 years, this is creeping up. And it does take time for these largely favorable patients to actually die of their disease. And this is something I've always found a bit disturbing. This is the results of treatment for the 30% who progress. We're not doing very well. We have to find these patients sooner so that we can weed them out of the surveillance paradigm and deal with them appropriately more promptly. So the problem is how trying to find the Gleason 7s, and we've been dealing with this for quite a while. This was back when I was working in Toronto at University Health Network, and the work by Fleshner, Jewett, and Trachtenberg, looking to see what the correlation of biopsy Gleason score was to final radical prostatectomy. And again, 50% of the biopsy 6s are actually 7. And in terms of margin status, seminal vesicle involvement, tumor volume, PSA failure rates, these undergraded 7s behave just like the biopsy 7s. They're not wimpy 7s, they're the real thing. So you have to find them. So they created a nomogram using a lot of easily available information, digital rectal, PSA, ultrasound findings, prostate volume, biopsy pattern, whether it was extended versus sextant, percentage of cancer in the biopsies, inflammation, PIN, all these things, and put together a nomogram, which looks like this. And so this is a nomogram not for, outcome. This is a nomogram to say, is this guy likely to be a Gleason 7? And I thought this was really good work, but they used it to justify doing surgery for these patients because they wouldn't be appropriate for brachytherapy. So I took 2 years of my brachytherapy patients and fed them through the nomogram and found out that the median predicted Gleason score upgrading from my brachy patients was 51%. The median PSA 4 years after brachytherapy for these men was 0.07, so I think they'd all been treated quite effectively. Of the 220 patients, there'd only been 5 biochemical failures, and 4 of them had had negative prostate biopsies. So there's no correlation between the most recent PSA for these men and the predicted likelihood of Gleason score upgrading. So we know that upgrading to a 3+4, or maybe even a 4+3, is not going to affect things, or your results from brachytherapy at least. These are results from the BC Cancer Agency on 2,000 men. Half are intermediate risk, half were favorable risk. All were treated with brachytherapy monotherapy. And you can see out at 12 years, there's no difference between the success rate for the two treatments. But what about if you end up upgrading to an 8 or a 10? Is that going to make a difference? Well, it certainly makes a difference to your treatment approach. And this is data from the SEER database on 27,000 men treated with external beam. And you can see that the Gleason grade and score certainly makes a difference in outcome when you're using external beam. So the implications of change in management: brachytherapy monotherapy is good for 3+4 or selected 4+3, but if you've got a high volume 4+3, you're going to have to add additional external beam, and this increases your grade 3 toxicity from 3% to 7%, according to the recent RTOG trial, which I'll be talking about tomorrow. And if they're high risk, then you require addition of androgen deprivation. If we're using brachytherapy, we can limit that to 12 months, but this also increases toxicity and decreases quality of life. So what's our role of multiparametric MRI in finding these patients earlier? This is obviously the most promising of the imaging modalities, with a 31% increase in detecting significant cancers, and also decreases the detection of the insignificant ones because they don't show up so well. And it also enables assessment of the location, the size, and the stage of the lesions. And I find that using an endorectal coil markedly improves the staging ability, particularly extraprostatic extension. You may get away with it if you've got a 3 Tesla, but I think it's essential in a 1.5 Tesla, which is all we have in Kelowna. So if someone's biopsy naive, but they have an elevated PSA, if they have a negative MRI, then you may defer biopsy and just watch them for a while longer. If they've got a negative biopsy, but the PSA is going up, then as in the cases that I've shown, you evaluate for a missed lesion. For positive biopsies, it's really useful in staging and guiding treatment and allowing dose escalation to the DIL. And in active surveillance, about 1/3 of patients will be upgraded as a result of MR ultrasound fusion biopsies. And perhaps at some point this may replace the need for the regular repeat biopsies. There are false negatives, though, as Laurie was mentioning, about 5%, and these are due mainly to patients who have a really high BMI, who have discontinuous cancer, where it's sort of peppered throughout but in really small volumes, or just a very low volume tumor, or if the fusion was inadequate. The negative predictive value for extraprostatic extension is about 90%, and you may also, as I showed, find other high-grade lesions that you didn't know about from your ultrasound biopsies. I think this data has been presented already. Recabal in 2016, 200 men, two-thirds of on active surveillance, and two-thirds of them had a region of interest on their multiparametric MRI, and this was 1.5 Tesla with an endorectal coil. They all had 14 cores systematic biopsies plus 2 cores cognitive, aiming for the MRI thing, and 2 cores fusion. And if you only biopsy things that are PIRADS 3 and above, you decrease your total number of biopsies by 35%. You may miss a few tumors, but they found over 300 significant cancers per 1,000 men. So just around the corner, it's just around the corner for us, cell cycle progression genetic testing. For some of you, it may already be in your living room. It's going to be really useful. It's similar to Oncotype DX, which some of us are much more familiar with for breast cancer because that determines the benefits of using chemo. It minimizes biopsy sampling error because Gleason pattern 3 coexisting in the same prostate with pattern 4 and 5 will have the same genetic profile. Now, I was a little disturbed by the end of Laurie's talk where he's showing the different distinct lesions with different cell profiles. So maybe what they're talking about here is pattern 3 and 4 in the same lesion, having the same genetic profile, but not necessarily different lesions within the same prostate. But a high cell cycle progression score can certainly help indicate when there's aggressive disease and you should be pulling them out of the surveillance queue and treating them. It's still investigational, but it has been associated with very fundamental aspects of tumor biology. It's associated with adverse pathology at surgery. It can predict the time to biochemical failure and the time to distant mets, associated with prostate cancer-specific mortality, and it can change management in about half the patients. Currently, we're doing this in Kelowna. I have this monotherapy randomized trial for intermediate risk patients, and they're randomized between an LDR seed implant or HDR brachytherapy. But for all these men, they get to have a multiparametric MRI for staging to identify the DIL for dose escalation. And then I do targeted biopsies to verify what we saw in the multiparametric MRI to confirm the presence of the lesion, and we send the tissue off for Polaris testing. So none of these guys get hormones or external beam. They're all either 3+4 or 4+3. They all have had their multiparametric MRI with an endorectal coil. And so far in 20 patients for whom I have a result, one was downgraded to 3+3, but he still had a really much higher cell cycle progression score of 3.7. It was one of the highest. And one was upgraded to 4+5 and had a lower progression score. So we're putting this together. I think we still have to learn a lot. In terms of PSA, we can't throw the baby out with the bathwater. It's still a very useful test. I'm hoping the pendulum will swing and screening will come back into practice now that we are better able to discern who to treat and who to watch. Because if we get there too late, there are definite implications for this. The costs of castrate-resistant prostate cancer are enormous. If we use trimodality treatment for high-risk disease in Canada, and this is going to seem like a real bargain to you guys, it's about $12,000 for a year of ADT, some IMRT, and a brachytherapy procedure. And if we use this for high-risk disease, the ASCEND results show that 79% of high-risk patients are going to be disease-free at 9 years. But if these patients aren't found and treated in time and you get there too late when they've already got metastatic disease, then you've got a problem because the average duration of hormone sensitivity for high Gleason score disease is 2 or 3 years. And then what happens? Well, this is what happens. And many of our patients go through these things sequentially, one after the other, as long as their heart is beating. And it's like $200,000 to manage one patient. And we can't afford that. So in conclusion, active surveillance is appropriate for many favorable risk prostate cancers, truly appropriate for like 50% or more, and it's a matter of pulling out those ones for whom it's not appropriate earlier on. When you can't do that, you end up dealing with more advanced and aggressive disease, and I think incorporation of multiparametric MRI and cell cycle progression testing is going to greatly refine the selection process. Thank you.